Hi, my name is Dev Mitra. I am an emergency physician at Alfred Health and Professor of Critical Care Research at Monash University. I've been at the Alfred for 22 years as a clinician and obviously love working here. Opioids are this class of medications that are very effective in relieving pain, but they're also associated with a lot of harm. Particularly the potential to overdose and also dependence in the long term. What we are finding is despite the safe prescribing practice and the education, about 30 to 50% of our patients continue to be prescribed opioids for pain when safer alternatives do exist. So through this research, what we were aiming to do is to find a way to reduce the use of opioids where safer alternatives are available. So what we did was a randomized controlled trial, with regards to standard practice, what we currently have are all these education programs, what we have is an analgesic ladder that prescribes or informs safe prescribing guidelines for clinicians. What we did in addition to that, the intervention was a restriction of oxycodone, or the most commonly prescribed opioid tablet in the emergency department. We restricted its access, which was that doctors could only prescribe it after approval from a senior clinician, and the medication would only be available through a senior nurse or a clinical pharmacist. The other arm was standard care, where doctors could prescribe as they felt, and it would be readily accessible by nurses. And so patients were randomized to a week of restricted access or a week of standard care access. Yes, so we randomized just over 2,200 patients who presented with pain to the emergency department. And what we found was that, consistent with what we already knew as our standard practice, that 22% of all these patients in the standard care arm continued to receive opioid or endone or oxycodone as a prescription. While when we restricted access, only 6% of patients received oxycodone. So we were able to reduce the rate of oxycodone prescription from 22% to 6%. In parallel to this, what we also found was that for patients who were being discharged with an analgesic medication, only 6% of them were given endone after being restricted, while there was 12% in the standard arm got an endone prescription on discharge. What we did find was that there was greater use of another medication called tapentadol, which is similar to an opioid but works slightly differently in ED but not at discharge. The other safety measures, such as time to effective analgesia to patients, remained unchanged. So we concluded this was a safe intervention. What we are seeing when we are attempting to change clinician behavior is that when we put out guidelines and education, that there is a long delay to those guidelines being taken up in practice and actually changing behavior. While if we put restrictive practices in place, there can be more rapid changes possible in the short term. So what we are hoping is to continue this restriction of a potentially harmful medication as standard practice.